So welcome everyone to today's session. My name's Jane Knight and I'm a clinical associate with the Medra MSSO, and I'm also joined by my colleague, Dr. Carol-Ann Wilson.
Hello everyone, welcome.
And there we are, I'll give you a wave for those of you with us live. Thank you for joining us so promptly. So first slide is one I'm sure you've seen before. It explains that Medra came about in the mid-1990s. It was an ICH initiative at the time. The MSSO was put in place to maintain and distribute Medra, and the activities of the MSSO are overseen by a management committee with representatives from both the industry and the regulatory authorities across the ICH regions. The next slide is copyright, explaining about the slides. Well, as I've already mentioned, we don't share these slides, but if you do quote it, if you mention it, the material and everything we're going to present to you today is owned by ICH, just like Medra itself. So you have to acknowledge that if you quote it or use it in any way. I've already mentioned we want this to be a workshop format. We want it to be interactive with your questions and comments. So please do use the questions panel to comment on the examples. Carol-Ann and I will take it in turns to present the examples and answer your questions. Sometimes we may not all agree on how the terms should be coded because we have picked some challenging terms. We can't take requests to code specific verbatims today via the questions, but you're welcome to share your examples with us. You can email us in advance, or there will be at the end, there will be a survey, and that you can put them in the survey if you have examples you want us to cover. One of our regular attendees sent me a list recently, so we've got some material which is too late to use them for this session, but we'll be able to look at them for next session. So if that's of interest to you, you can take that opportunity. So first, where's our polling gone? Now we say that you need to log on to in order to vote in the polling, the quizzes that we have. The easiest way to do this is to scan the QR code, but you also, if you prefer, you can join on your computer. You go to an internet browser, something like Safari, or Chrome, not Google as such, and you just type into the URL polev.com, nothing else, no HTTP, just polev.com. When you see the screen on the right hand side, you enter my name, Jane Knight 855. That will link you to the presentation, and then you'll be able to vote in the polls. So I see some of you are on it already. Australia,
India, China,
India, welcome. And lots of you in Europe. I can't make out. I can see the edges. I can see
Spain,
Spain,
crowded
Turkey, Italy. Welcome. Wherever you are in the world, it's lovely to have you with us. North America, United States, welcome. Very early for you. Welcome there. So here's the credentials I mentioned for the web-based browser, and Carol-Ann's going to put these credentials in the chat. She's done it already. This is a demo access to the browser. If you don't have your own access, and if you want to use the browser, this is for you. You go to it from the home page, top right-hand corner, there's a quick link to the WBB web-based browser. We'll be using the older web-based browser. I know there's a new release out, but we'll be using the existing older one just for now until we're all more familiar with the new release of the browser. So there's not always an exact match. We all know this when we code. Sometimes we may be torn between two LLTs, two possible approaches. Even the points to consider document sometimes gives us options for coding. Sometimes we understand a term differently. And so we have to do the best we can in coding. We call it a best approximation. But overall, we must always code as reported without making any assumptions, without adding information or leaving anything out. And as you know, if you've been with us before, we always have a picture or there we go. Sorry, it's a bit of a delay today. We always have a picture to illustrate that sometimes the words we see in the verbatim term are not exactly easy. We don't always understand a term in the same way. And I brought a cartoon along today where the mother says to the child, "Your shoes are on the wrong feet, young lady." And the child takes this literally and responds, "Why? Whose feet should they be on?" So you see there with the words, we may take it for granted how we understand those words. And it's only when you ask a colleague how they understand a particular reported verbatim that they may have a different understanding. So it's a balance between applying coding rules for consistency and medical judgment so that we can manage the risks to patients. We use medical references a lot, and you'll see us doing this in the session today to make decisions. And sometimes it's necessary to add a new term, ask for a new term to be added to MEDRA if you can't find the reported concept or a synonym within the MEDRA terminology itself. So, having said all of that, I'm going to turn my camera off because I know it can be distracting, and let's code together. So the first example today is feeling overwhelmed. So the first question when we see that is, what's being reported? Is it a subjective experience? It mentions feeling. That makes me think that it's something subjective the patient may be describing. Is it physical, overwhelmed because they're limited in some way physically, or is it a mental condition, which is what immediately springs to mind? So how are we going to code this? How would you code this? Feeling overwhelmed. This is where you can join. You can scan the QR code top right and you can join. If you haven't been in the sessions before, you vote in the polls how you would respond. I'm reading some of these. Discouragement, feeling of despair, stress, or is it the activities of daily living impaired? You'll probably guess from seeing this list, there isn't a term in MEDRA using the word overwhelmed. So we have to understand what's being reported and find the best match. Let's see how your voting is going. I see there's about 50 of you voted so far. Let's see where your feelings are. Feeling abnormal is a very common choice there, popular choice, because we don't really know what it means. That's always a good fallback term, isn't it? Feeling abnormal when it says feeling. Let's see how our thought process, I'll close the poll. That's the most popular choice so far. And I'm going to go to the browser myself to see how I would look. So I'm going to go to the web-based browser from the website, and it's put me into Chinese today. Let's take it back to an English.
On the top.
Oh no, I have to move the bar. Just bear with me, everyone. There we are. It's obscured by the grab bar thing, the new tool. So I'm into the browser now. Let's search. We know there's nothing for overwhelm, but I'll just confirm that and show you there's nothing in overwhelmed, nothing there. So we need a feeling term, don't we? What is it? There's always a good idea to look. If you have a report of feeling or sense, sensation, feeling or felt, have a look at what the options are here. There's a lot of feeling there. So I'd have to look through all of these. There's the feeling abnormal that some of you chose. Feeling detached, feeling down, feeling guilty, floating, high, hungry, jittery. What is it? Feeling overwhelmed, feeling of despair. That was one that we found ahead of time. That might be the best we can look at. It's very hard. So when looking through all of these, it makes me think I really want to, I'm feeling, all kinds of feelings, tense. I really need to have some idea in my mind of what overwhelm means. What do I think it's meaning? So if I think of being overwhelmed, it makes me think that I'm not coping, that there's demands placed upon me that I don't feel able to cope with. And that, in my mind, is how I would think of as stress. That's what the word that springs to mind when I think of that. It's a mismatch between how I perceive my body can cope compared to the demands, physical or mental demands put upon it. That's what I think is the definition of stress. So I'm just going to have a look and see what stress terms exist in MEDRA. There is a PT for stress, just stress, and it comes under anxiety in the hierarchy. And there are all these other stress terms here. Again, lots of terms: acute reaction to stress, acute stress disorder. Would that be an overwhelm? That sounds like it's under stress disorders, anxiety again. Am I making a diagnosis there? Psychiatric conditions. It's tricky, isn't it? The other thing I could do is to go, there's a lot of there that we'd need to look through. The other thing I could do, I could go to the psychiatric system organ class, and I could have a look down and see, what do we have here? We have anxiety disorders, but are we diagnosing there with anxiety? We've got anxiety symptoms, agitation, anxiety, nervousness, stress. That's where the stress term, I quite like that term. Stress symptoms, LLT there. That might be a feeling overwhelmed. I quite like that. Something in my head thinks stress is a good way to go. We look down, we've got some other mood disorders. We've got emotion and mood. Feeling sounds like it's a passing thing, that it could be a mood, emotional problem. Morose, screaming. For discouragement, that's the other term we found ahead of time. Am I feeling discouraged that I can't perform as well? We don't really know. So I'm going to go back to my slides rather than waste any more time looking around. And let's look at some references. This is the acute stress disorder that we saw. This is something very specific. It's an acute stress reaction that develops within a month of exposure to a traumatic event. So this is like a post-traumatic stress disorder. So we must be careful about just picking up terms randomly in the browser and without referencing them, because we see here that's not suitable. Dorland's describes stress as being a state of physiological, psychological strain caused by adverse stimuli, physical or mental, that disturbs the functioning of an organism. So here, this is a bit what I was saying about there's a stimulus and you don't have the capacity to deal with it, a mismatch. That's how I understand stress. A state of worry or mental tension caused by a difficult situation. So that's starting to sound like overwhelm to me as my sense of what the term may mean. The way we respond to it, the psychological perception of pressure and the body's response to it. That's my layman's understanding of it. Stress is necessary, but it's this mismatch. So as a learning there, I would search the terminology for feeling terms, take the time to look through them all. You can also look in the HLT for feelings and sensations not elsewhere classified. If you don't find a suitable term, explore the SOC of psychiatric disorders to identify other preferred terms. You're looking overall to capture the meaning of the report. And if you don't feel that there's a suitable term, you do what you all did in the poll and select the LLT feeling abnormal. So overall, I would choose stress symptoms because I've done some research. I like the meaning of the term, and I that's the one I would go. But when we were discussing this, Carol Ann and I also looked at the term discouragement, and we felt that that was another option. And failing that, if you don't like either of those, then you could go for feeling abnormal, but it doesn't tell you very much. So that's what we would do with that term. So I'll just pause for a moment while you get your questions or comments in. If anybody's got questions or comments they want to share. Caroline, so far?
There's a comment from Martin. So he says that in his company they see such terms, so like feeling overwhelmed very often. and they are reported in context of training how to do self-infusing, for instance.
Ah,
So difficulty to use a product, but also when people discuss their diagnosis and have issues accepting their fate. So
yes. Yes, handling bad news or
yes,
handling medical information or medical procedures. That's really interesting. I hadn't thought of it like that, but yes, giving the context around the terms really helpful. Thank you, Martin. It's good comments there. Yeah, thank you.
no further
Interesting.
questions. No further
Thank
questions. No
you.
further comments so far,
It
Jane.
was it was a real report, that one, so I'm not sure quite the context of where it came from. Thank you, Carol Ann. So the next example is a lot of fatigue in the bones, and they've told us here that there's an unknown diagnosis. So what's being reported? Is it a feeling again, a feeling of fatigue or tiredness? Or in the bones, though, doesn't quite make sense. Or is it like we hear the metal fatigue? Is it like structural change to the bones that they've somehow got weakened or they've become fragile? What does fatigue mean in this context? And therefore, what's the most appropriate LLT? Bearing in mind, we probably can't query this term because they've already told us they don't know anything else. So my go-to reference is Dorland's. Fatigue is a state of increased discomfort and decreased efficiency resulting from prolonged or excessive exertion. So like the tiredness, but look at the second definition here, the gradual fracturing of a material due to repetitive or cyclic stress. So this is some kind of small, not really trauma, just bangs or vibration or something, repetitive stress on a substance. So this could relate to bones. So we're still not sure. We can't rule either of them out, but let's do a search for bone fatigue. Now, this is an article I found around bone fatigue monitoring. Oh, I think Caroline, you found it for us. I mustn't take the credit. This one relates to space flight, and it points out that bone fatigue often manifests itself as stress fractures. So this is going back to the Dorland's definition, where the second definition said it could be fracturing due to repetitive stress on a substance. So it could be a stress fracture. And this article goes on to talk about space flight because it affects your bones being in space without gravity. So your bone surface, your bone structure breaks down almost without the repetitive, the remodeling. It's what it comes to. So bear with us. We've got another article here. So this now is talking about the bone tissue itself. I'm not going to read all this. The main thing to point out is it's the bone remodels itself, and it says in there it's properties that permit continuous adaptation to the mechanical stresses imposed on the tissues. So the bones have a particular structure with a periosteum and an endosteal lining formed by dense connective tissue. It protects, nourishes, assists in bone formation and fracture repair. So it's this idea that the bone's constantly renewing itself, remodeling, coping with the bangs on it. I don't know what else to call it, the stress, the little knocks to the bones that we have through exercise and other things that as we move around, helps our bones strengthen by adapting, remodeling over the lifetime. Again, mechanical properties of the bone are not identical in all directions. Constant remodeling, different properties in different periods of life, as we know as we get older. So it's about this bone. So what I'm trying to show you is that the properties of the bone affect the mechanical quality of bone, increasing susceptibility to fractures. So this is to do with this fatigue. Fatigue is a breakdown somehow of this process protecting our bones against fractures, which is how the reference started by saying that bone fatigue often manifests as stress fractures. A lot of information there, so you can put your questions in if you wish. I'm just going to make my browser a little bit smaller so I can fit more on the screen. So let's have a look at fatigue. Let's see if there's anything with fatigue. So we've got the fatigue term that we know about, which we know as a preferred term. It's under asthenia. That's the tiredness. Having done the research, I don't think this is reporting tiredness in bones because it's so specific to bone fatigue, mentioning bone. So I'm going to have a look down what we have here. Battle fatigue, cancer fatigue, fatigue fracture jumps out at me there. We have stress fracture under the injury, poisoning and procedural complications system organ class. A fatigue fracture falls under that PT of stress fracture. So again, this reinforces for me that where I was referencing is probably what the reporter intended. I can go to the browser and have a look around the stress fractures and see what there is there. There it is, fatigue fracture, stress fracture. The other thing, traumatic fractures, pathological fractures, bone. But it's not saying there is a fracture, is it? It's saying that there's a problem with the bone remodeling or the replacement of the bone, the natural structure of the bone and the replacement. So rather than, I could look around and I could look at all these, but if you're not sure of the bone, where to find the terms, you can enter something in. So let's do it the easy way. Let's look up remodeling, because that was one of the terms that came up in our medical references. And again, we see immediately there's a bone remodeling disorder under a bone metabolism disorder. Bone metabolism disorders there, bone metabolic. So it's a multi-axial preferred term. I can see on the right-hand side the placement of it. It's there under musculoskeletal and connective tissue disorders, bone disorders. Let's go and have a look at it. I quite like the look of that. Bone metabolism or bone remodeling, one of these two under the PT, the concept of bone metabolism. That's what I think is being reported. So I think that's the one I'm going to go for. We've got the American English and the British English. I think I'll plump for that one. So let's have a look. Let's see. What would you do? I've told you my choice there before we've done the poll, but maybe we'll. Fatigue fracture, bone remodeling disorder, bone pain, or a bone disorder. So I'll move on quite quickly because I think we've all looked at it together. Fatigue fracture, some of you like. That's interesting. I didn't choose that one because it seemed like the references said the bone fatigue may manifest as a stress fracture. So it could be there within the patient's bone structure and you only see it when there is a fracture. Doesn't mean that there are always fractures when you have the bone fatigue itself. So it's either between those two. I see you're changing your mind now. Some of you prefer to be more specific with bone disorder. Again, more general. It's just how confident you feel with your referencing. So we would reference to understand the concept of bone fatigue, understand what's being reported. Could it have a different meaning? But this is what I'm saying when fatigue, immediately I think of tiredness, but then I see bones and I think, no, that does not right. I don't think that's what they meant. So we do our references, we use medical judgment to find the closest term, not necessarily just the exact word of fatigue. And although clarification would be ideal, the report states that we can't query, so we have to code it. So I would select a bone remodeling disorder, which could lead to stress fractures, but fatigue fractures haven't been reported, so that's where I'd choose. Oh, lots of words there, Carol-Ann, lots of referencing. And have you got anything to add, Carol-Ann? I know you helped me with some of this referencing. Anything to add?
Nothing to add so far, but we have a comment again from Martin. We see this very often reported in context of training, how to do self-infusing, so difficulty to use the product. No, that's the old one.
That's the old one.
That's the old one. Yeah, so there's nothing
No new?
from the attendees. No questions from the
No.
attendees regarding this verbatim. But I think we discussed it a lot, so I think that
Yes.
just coding it to bone disorder would be too vague. We have some more information, and we really came to the agreement that fatigue in bones has something to do with disbalance between um, stress on the bones and remodeling of the bones
Yes.
in order to keep them, yeah, it's like fragility of the bones. Yeah.
Yes.
Could be due to osteoporosis, to injuries whatsoever. And that's why we thought that this bone remodeling disorder, so a disbalance between um, yeah, stress to the bones and restructuring of the bones would be the best approximation to this verbatim.
Yes. Thank you, Caroline. Good. So I'll hand on to the next example and move on and hand over to you, Caroline, to share the next two examples with us.
Yeah, there's one more question. Do we have an LLT heavy feeling in bones? I don't think that
Heavy
we have that.
bones,
No.
heavy feeling in bones. We've got heaviness in Medra, a few places, but I'll just have a quick look. Heavy. I'll just put the stem there because it'll catch. We've got heavy metals. We've got like breast heaviness, chest heaviness, eye heavy, arms, legs, head. Not bones. Heavy
No.
smoke, heavy sweating. No. I put bone in as well. Heaviness in bones. I don't think so. No. Okay, I'll hand over then, Caroline.
Thank you. Me share my screen now. Here we are. Can you see
Yes,
it, James?
yes.
Okay. So next, an amnesia is reported.
No,
It is covered.
hold on, Caroline. It hasn't come. Hold
Hasn't
on.
come yet.
No. Let me. Let me just check again. I'm not seeing it. Now I can. Okay, I think
Okay.
there's a bit of a delay with our new application. So
Yes,
apologies, everyone. It's the first time we've used the new format. So
in
thank you,
new
Caroline.
format. Yeah,
Sorry to interrupt.
we did some exercise and tried it, but it's really quite different from what we had before. So here we have this amnesia, and it covered a period from the start of a convulsion for some hours after this convulsion. So are we clear about the type of amnesia and also about the type of convulsion that we are looking at? Can we find a combination term? And what would be the most appropriate LLT or LLTs? So is split coding required at the end? So next question for you. How would you approach this verbatim? Would you select convulsion and or amnesia transient or transient global amnesia or a combination term transient epileptic amnesia? What would you do? So I see you're still voting. Let's have a look what you're going for. So most of you are going for amnesia transient. Many of you would select transient epileptic amnesia, convulsion as well. So we have a split of opinion. Transient global amnesia, only 2% of you are going for it. Most of you would select amnesia transient or transient epileptic amnesia. So let me close the poll and switch to the browser. Where am I? Here. Let me log in. Again, Chinese. So here we are. So let me first look for the term convulsion and see what we can find when searching for this term. right mouse click, go to browser. We have a direct match here. And here is our LLT convulsion, and it's grouped under PT seizure. So convulsion can be considered a synonym of seizure. And you see that there are plenty of seizures and convulsions that are listed under this PT seizure. So new seizure type, seizure cerebral, some more vague terms, no specific ones. Convulsions generalized, aggravated, breakthrough seizure. So that would be, convulsion would be one of the LLTs that we would need to consider. So what about the amnesia? Let us search for amnesia. So we have amnesia here, again a direct match. Amnesia transient, this was the one that we saw in the poll. It's grouped under amnesia, so a vague term. What else do we have? Here we have the transient epileptic amnesia and also the transient global amnesia. And if we look into the hierarchy, you will see that transient global amnesia is represented on PT level. That means it's considered a unique medical concept, something more specific than it was reported in our verbatim. And same is true actually for the transient epileptic amnesia. Transient epileptic amnesia, when I go to the browser, again under nervous system disorders, we see that the transient epileptic amnesia is even grouped under a different HLT than our PT seizure. It's a partial complex seizure, so it's again a very specific term. So, and we should of course not code more specifically than what has been reported. So let me go back to my presentation. Here we are. And have a look into some references to better understand these reported conditions. We saw that a convulsion can also be called seizure, and a seizure is caused by an electrical hypersynchronization, so an abnormal electrical activity in the brain, in the cerebral cortex. And it may cause changes in the level of consciousness, behavior, memory, or feelings. There are two types of seizures. They can be either provoked or unprovoked. A provoked seizure, also called acute symptomatic provoked seizure, refers to a seizure that occurs at the time of a systemic insult or dysregulation or in close temporal association with a documented cerebral injury. It may be caused by metabolic derangements, drug or alcohol withdrawal, as well as acute neurological disorders such as a stroke, encephalitis, or an acute head injury. And they may recur during this index illness. All of them generally carry a low risk for future epilepsy. Now, what about unprovoked seizures? These are seizures of either unknown etiology or seizures that occur due to a pre-existing brain lesion or due to a chronic progressive nervous system disorder. And they carry a higher risk of future epilepsy compared with acute symptomatic provoked seizures. Now, how is epilepsy different from these medical concepts? Epilepsy is characterized by recurrent unprovoked seizures, which occur more than 24 hours apart. So having one or several seizures, like in our patient does not mean a person suffers epilepsy. Additional information is needed in order to make this diagnosis. For our patient, only one convulsion is reported. And we don't know whether the patient suffered from additional convulsions before, nor whether the convulsion was a provoked or an unprovoked type of convulsion, meaning that the assignment of the LLT transient epileptic amnesia would be incorrect. We also saw that transient global amnesia is a separate PT representing a unique medical concept. This condition mainly affects people who are between 50 and 80 years old, only few people younger than 40. It is quite rare, and affected patients experience a sudden and transient memory loss. So this would fit with our verbatim, but because it doesn't last longer, just a few hours. But affected patients experience both an anterograde and a retrograde amnesia, whereas in our patient, only a retrograde amnesia for some hours after the convulsion was reported. So again, would not be suitable, too specific. One of the main coding rules in the Verbatim selection points to consider document, and you see the latest version here, a screenshot of the cover page, is the following. Select terms for all reported information, do not add information. Jane mentioned this already in the introductory slides, code as reported. First of all, we should not exclude medically relevant reported information when coding. But also we should not add information, for instance, by selecting a term for a diagnosis if only signs or symptoms are reported, or by assigning a term that is more specific than what has actually been reported. In summary, when coding similar scenarios and not being an expert in this field, refer to reliable references to be able to clearly distinguish between related, similar medical concepts. Do not make a diagnosis from vaguely reported events, but always search the MEDRA hierarchy to capture as much information as possible from the verbatim. Here it was the transient occurrence of the reported amnesia. And these are our final suggestions. We would code to LLT convulsion under PT seizure and to LLT amnesia transient under PT amnesia. Are there any questions, Jane?
Not exactly, Caroline. We had a suggestion of the anterograde amnesia. So it's interesting because that was one you referenced it and you've given us the rationale why you wouldn't select that. But
Yeah.
interesting that our attendees are along the same line of thought as you. So there was also a suggestion of when you searched, you didn't search for memory. Could we have found a term with memory in it?
Let me switch to the browser again.
Amnesia,
Memory.
Amnesia, I suppose it's
Long-term memory
synonym,
loss,
really.
losing memory, loss of memory
Losing
ability,
memory.
memory deficit. It's more partial loss of memory, short-term.
Yeah.
So these are more total loss of memory. These are more. It's a memory would of course be a synonym you would look like, but you see that they are much more vague than the
Much
ones
more
we
vague,
saw.
more
With
partial. What's the PT for total loss of memory, Caroline? What's the memory loss, I
also
suppose?
amnesia.
Oh, amnesia. So
Yeah,
same concept. So
yeah. It's not a total loss. We know we have more specific information. It's for a defined time period, for some hours after a convulsion.
Thank you. So that was all we had so far with the questions. And we had a comment going back to the bone example, that how people talk the fatigue in the bone, how people's expression of I'm tired to my bones, I'm tired to my bones. So maybe it's a colloquialism potentially, but
Yes,
I still like it.
I was thinking
Mm,
of that when we discussed it, Jane,
I'm
because in
tired.
German there's actually like a phrase, so a lay term where you say, well, I have tiredness in my bone, and what you
Oh,
mean is really tiredness, fatigue.
oh,
But it
interesting.
wa- it was not reported. Fatigue in the bones, although
Yeah.
fatigue is a synonym for the late term tiredness. It's fatigue is a more medical term, and that's why I would rather go for a more specific condition.
As reported.
Yeah.
Interesting, though, that culturally the translation can affect things, isn't it?
Yes, yeah, often the case. It's often the case.
Thank you, Caroline.
So the next one then. So in our next patient, a cardiac arrhythmia was associated with several episodes of loss of consciousness and collapse. So is it clear what is being described here? Is there a causal relationship between these events? Do we know the reason for the collapse? And what does collapse actually mean? How to approach this verbatim? So in this instance, we would like to ask you to enter your proposals yourself. So use your browser, also the MSSO browser. You have the details, how to access it in the chat. Cardiac arrhythmia with loss of consciousness on collapse on several occasions. So the underlying condition is the cardiac arrhythmia. 2 LRTs, yeah, you would split code. Arrhythmia, yeah, correct. Consciousness loss and cardiac syncope. Interesting. Any further suggestions? So cardiac arrhythmia, that's fine. It's a direct match. So that's the underlying condition. Arrhythmic syncope. Yeah, you're going for that. Others would split into cardiac arrhythmia, loss of consciousness, and collapse. So thank you. So we have a split between cardiac arrhythmia and arrhythmic syncope, and cardiac arrhythmia, loss of consciousness, and collapse. So thank you for joining. So let's proceed and look into the browser. Here we are. So cardiac arrhythmia, of course, is a direct match in MedDRA, and you have most of you have voted for it. Here it is, cardiac arrhythmia grouped under arrhythmia. That's the underlying condition. So what about collapse? Oops. Collapse is a non-current LLT. So something is wrong with this LLT. It's grouped under circulatory collapse, under circulatory collapse and shock. So obviously a serious condition. Decreased and non-specific blood pressure disorders and shock. So circulatory collapse, it's grouped, it's a non-current term, so we should not use it. It's grouped under circulatory collapse to give at least one option how to code that when you are not able to clarify the background, the medical background of the reported collapse. And it's going worst case, like often. So the approach here is worst case because it's grouped under circulatory collapse. So quite a severe, serious medical condition. What about loss of consciousness? Consciousness loss, loss of consciousness, here it is. So let me now delete the non-current terms, otherwise we have a long list. Here it is, loss of consciousness. And we also have a transient loss of consciousness because we know based on our verbatim that this was only a transient loss of consciousness, just for a few hours. Oh, several episodes. Okay. But Both the terms, the collapse and the transient loss of consciousness in our verbatim, somehow they refer to each other. They describe a sudden and temporary loss of consciousness in the framework of cardiac arrhythmia. So the patient temporarily lost consciousness and suddenly somehow fell down, collapsed on several occasions. It was an acute transient event due to arrhythmia. So let's have a look at the other PTs that are grouped under the LLT transient loss of consciousness. Here we have our loss of consciousness and the transient one. So let's look what we have in addition. So some very specific depressed level of consciousness, hyperglycemic, hypo, infant, postictal. And here we have the syncope and a term that is called arrhythmic syncope or cardiac syncope. So arrhythmic syncope would even more specific because we know that the loss of consciousness was due to arrhythmia. So would this be a suitable LLT assignment then? Let us reassure ourselves. So let's look into the door lens. And you see that collapse is a state of extreme frustration and depression with failure of circulation, so general failure of circulation, or an abnormal falling in of the walls of any part or organ, so like the lungs or a vein, for instance. So it's really it's a very ambiguous term. Whereas syncope is a temporary suspension of consciousness, so a temporary loss of consciousness due to a generalized cerebral ischemia, and it's also called faint. And a cardiac syncope is due to a cerebral anemia caused by obstructions to cardiac output or arrhythmias, such as ventricular asystoles, extreme bradycardia, or ventricular tachycardia. So, and this type occurs suddenly with no previous symptoms or only momentary ones. So the term cardiac syncope is not as specific as the one that we could find because we found an even more specific one, the arrhythmic syncope. So that's why we would go for this one. So what are the takeaways? Always reassure yourself whether a given reported term or abbreviation is ambiguous or not. The term collapse is definitely ambiguous, and if no additional information is provided in a given verbatim, like in our case, such reports have to be queried. When looking at our verbatim, we had to apply medical judgment because we had some more information in our verbatim. It was not just a reported collapse. We had to combine the given information and make sense out of it. We did not add information, but we have evaluated the information medically based on good references. So we applied medical judgment. And to best capture the reported medical concepts, we explored the Medra hierarchy and have found a perfect combination term for the reported episodes of loss of consciousness and collapse caused by the cardiac arrhythmia. And with this, here are our final proposals. We would, of course, code the underlying condition, the cardiac arrhythmia, and we would, in addition, code the LLT arrhythmic syncope under PT syncope, because you cannot argue that cardiac arrhythmia would be sufficient and that the syncope is a characteristic symptom of the arrhythmia. You know that in the Meta Points to Consider term selection document guidance, we in the preferred option, we are asked to, if you have a diagnosis with signs and symptoms, that you would only code the diagnosis. But this is not our scenario here. The syncope is not characteristic of a cardiac arrhythmia. So palpitations would be characteristic in this instance. But the arrhythmic syncope represents a complication of the cardiac arrhythmia, and this needs to be captured separately. Any questions, Jane? Other questions?
Sorry, Caroline, just a comment. Martin was saying that what you were saying there, that it gives greater severity as well.
Yeah.
Somebody was suggested about faint and collapse, because collapse being non-current, but you can't assume that every collapse is a faint, can you?
No, no. It could be a circulatory collapse, yeah. And this is how it's grouped in MEDRA now, taking the worst case approach. But here we have loss of consciousness and collapse on several occasions based on cardiac arrhythmia. So it's a sudden collapse. It's a falling down due to unconsciousness, due to the cardiac arrhythmia.
And then there was the comment, why didn't you code the collapse? Well, you have coded it through the syncope, because as you showed us, the
Yeah,
basic LLT collapse is non-current, so we can't
yeah.
select that one.
We
So
can't select it. And the loss of consciousness and collapse on several occasions, this is one event. So not one event, it's several episodes, but represents one event on several occasions. So somehow we have to find a combination term for it. And collapse, as mentioned, is a non-current term. So somehow we have to make sense of it out of this description. And as I said, it's a temporary loss of consciousness. It's an episode. It's acute, and it's based on a cardiac disease. And so it's an ischemia, cerebral ischemia, causing this unconsciousness. And arrhythmic syncope is a perfect term to capture this condition.
thank you, Caroline. That's
So,
all
and
we have in the questions, I think, so far. Oh, here we go. Loss of consciousness is inherent to the syncope by definition in Dorland's. So thank you, Martin, for that. There's the last, I think that's the last one. Any
yep.
more? Any more? No, I'm finding the questions. It's yes, good. Thank you all for your comments and questions on that one. Well, I'll take over now again, Caroline, and
Yep.
share my screen.
Thank you.
Thank you. So here we have our next example is acute liver failure leading to progressively worsening encephalopathy. So what's being reported here? It looks a fairly straightforward term when I read it. What's being reported? Acute liver failure and the progressively worsening encephalopathy. Are they connected? Would we see them as being connected? Is it that we think that's medically feasible? Certainly, I don't have any alarm bells in my head there. Is progressively worsening important to capture? And what would be the most appropriate either single LLT or combination of LLTs? So let's browse. We're going to browse first of all. So let's do our acute. This should be quite straightforward, I think. Acute liver failure. So that's there, acute liver failure, the LLT with a PT of acute hepatic failure. And the browser's also brought me back the actual term of acute hepatic failure, knowing that liver and hepatic are synonyms. So the browser knows that I'd be interested. So it's there, acute liver failure. So what about the encephalopathy? So that's the encephalopathy, however, encephalopathy. Have we got that one there? So we've got several types here. So we've got just plain encephalopathy. We're told it's progressively worsening. So there are multiple types of encephalopathy. It can occur for multiple reasons. We look down here, alcohol, AIDS, anoxia, autoimmune disorders, bilirubin. So ideally, perhaps we could find one that has a relationship to the liver. Drug-induced. Well, we didn't say it's drug-induced, although acute liver failure may be. There is an anality of encephalopathy hepatic, which would probably be better than just choosing encephalopathy, because it has, as we see on the right-hand side, it has the relationship here to hepatobiliary disorders as a secondary SOC, as well as nervous system for the encephalopathy itself. So that looks like a good choice there. I can take it over to the browser just to have a look. While I'm here, we had a question in about the color coding of the PTs here. Just as I think most of you probably know this, I know it's something we've covered before. The red, the green, and the blue. If you get confused, you can use the legends at the top of the browser. There's a button for legends. The blue means that the primary SOC is what we're viewing here. Here we're viewing it in the nervous system disorder SOC. So this is the primary, what you'd see in your listings. But the term does have another link into hepatobiliary. We call any other link we call into a different SOC secondary, and that will be depicted as green. So that's what the color coding means. So let's go back. We've found our two terms. So now the question is, would you split it? It's a very simple poll this time. Do I just code acute liver failure and the encephalopathy as part of it? Or do I split code and code the hepatic encephalopathy separately? What would you do? And you can guess where we're going to take you next. We're going to take you to the measure term selection points to consider to see what the guidance says about splitting of terms, and let's see what everybody's thoughts are. Yes, most people would split. That's interesting. 2/3 of you would split. Interesting to see. So let's have a look at our references. So this is what's comes up in the measure term selection points to consider. The first section I've gone to is where it advises us how to code a diagnosis reported with and without signs and symptoms. So we see here that if there's a diagnosis with symptoms and those symptoms are characteristic, the preferred approach is to just code the diagnosis. So is hepatic encephalopathy a symptom of acute liver failure, or is it a consequence? Is it a sequelae, a complication? How do we view this? If it's a complication, and it's something that follows on in severe cases, for example, I would think we need to split. But if it's a symptom, then the guidance there is not to split. So there's also guidance in the PTC that says if there's a MEDRA combination term available, use that. So here we see some examples of things like diabetic retinopathy. So in that case, if I was to select hepatic encephalopathy, does that therefore encompass the acute liver failure? Would you only have hepatic encephalopathy if you did have liver failure? Or if we apply the diagnosis, signs and symptoms approach, would we just code the liver failure? Or do we code both of them? So then I went to Dorland's acute hepatic failure, a sudden loss of hepatic cell function, and it's with coagulopathy and hepatic encephalopathy. So it is a characteristic event, symptom or consequence or complication. We're still not sure, but they do go together. Then we have a reference here from the BNJ best practice, which explains what acute liver failure is. It's a rare, life-threatening, potentially reversible condition defined by jaundice, coagulopathy, and hepatic encephalopathy again. So we're seeing the same thing again, that it is characteristic. But we read on down, and at the bottom you see the definition there. It also tells us that acute liver failure may be classified as hyperacute, acute, or subacute, depending on the interval from the onset of jaundice to the development of the encephalopathy. So that then makes me think that it's not always that when the condition starts, all the symptoms are there together. the encephalopathy follows on after some period of time. We've been told it's progressively worsening. So, and the fact that we've been told it's there gives some severity information. Although MedRes doesn't have terms itself for severity, by coding it, we can probably capture more. And the points to consider document tells us that where split coding gives more clinical information, then that's something we should consider doing. So, what do I learn from that? Well, my thought process, as always, I would distinguish between the symptoms and possible complications. And I know that's not always easy to do. It's not always black and white, a clear decision there. So I would look to apply the coding guidelines as best I can. And I would consider whether there's a combination term available, whether two LLTs are better to be selected for split coding in this scenario. And if I am split coding and I'm selecting two, make sure that I choose the best LLTs. So by that, I mean not just coding encephalopathy, but looking for the hepatic encephalopathy LLT. So overall, I would use medical judgment to capture all the reported information because, as I've shown you in PTC, it could support either approach. My decision is to code acute liver failure and hepatic encephalopathy. And that's in line with what you were all advocating yourself in the poll. So hopefully everyone's on side with me there, Carol Ann, and everyone agrees that's what they were thinking of doing too.
So there's no comments and no questions so far.
Good. So let's move on to the next one. Good, I've been getting thumbs up there. That's lovely to see. Thank you. So now my next one is traumatic left kidney injury with normal eGFR. So we've got traumatic left kidney injury. Is this an injury or is it a spontaneous event? Is the first thing. Well, we're told it's injury and traumatic. So that answers that question. Is the acronym acceptable for coding, the eGFR, but it says it's normal. So does the lab value actually add anything? Or what would be the most appropriate LLTs then in this scenario? So again, let's go to the browser while you all have a think about it. So now I just turn my paper over. So I'm going to search for kidney and injury and see what I get. So the browser will know, just like it knew liver and hepatic, I can enter kidney and it will also search for renal. So kidney injury, I get 13 terms that have a synonym with them. So these include the word renal injury, traumatic renal injury. And then the terms with kidney in them are acute kidney injury, injury to kidney. But I'm just going to show you the hierarchy of these. Acute kidney injury goes under renal failure and impairment. So in medical terminologies, in medical speak, acute kidney injury actually means failure. It doesn't mean trauma. So this is something that if you're not familiar with this, you need to get used to when you're searching in Medra. And it shows, don't just grab the first term you see without checking the hierarchy. Injury to kidney, however, is under renal injury as the PT. And we see there it's multi-axial. It has a link to the urinary tract injuries in injury, poisoning and procedural complication, as well as being renal failure and impairment. But there's still not the primary. Look, the primary with the injury to kidney is still under renal. It isn't trauma. So we need to find a term that captures actually the trauma. And there it is there. It's with the renal rather than the kidney. It's traumatic renal injury. So this is very explicitly calling out the fact it was trauma and not renal failure. So now we see by looking at the primary and secondary on the right-hand side, the primary for this PT, traumatic renal injury, is injury, poisoning and procedural complications. And what about the eGFR? I can look and see if it's in Medra. It is in Medra with genes, but that's not what we've got here. Gene mutation. So again, we can't just grab a term. We have to see. So we need to find out, what does the eGFR mean? And it's glomerular filtration. Like, we can try with the GFR, because there was a mix of uppercase and lowercase, and there it is. It's GFR decreased, GFR normal. So let's take that one over to the browser and see what we get when we look at that one. It's glomerular filtration rate normal, and one of the LLTs there is estimated glomerular filtration rate normal. So the little e represented the estimated, and we can reference that if we look in a book of abbreviations, for example, but it's glomerular filtration rate, so it seems that it probably is an acceptable abbreviation. So would you split code it? Would you code both the traumatic renal injury and the estimated glomerular filtration rate, or not? Normal or not? What would you do? Let's see. I'll show you the responses. There's everyone's responses. Mainly you would split code. It's interesting that it has been reported as part of the verbatim term. It hasn't been picked up from another field somewhere, another part of the form. It's actually been reported. So that makes me think the reporter wanted us to know that, to think that it's significant. So the lessons learned are that we would search MEDRA for kidney injury terms, and you saw me do that. Check the hierarchy to make sure that you're not grabbing a term based on what's included without taking the time to make sure that it does represent the concept you think it does. Check the abbreviation as unambiguous, and I would code the lab result to add clinical information, because it's been reported as part of the term. Again, remember the last example where by coding the extra element gave a more rounded picture, gave us some idea of severity, really. We know here that although the main symptoms of a traumatic kidney injury may be trauma, bruising, bleeding, that kind of thing, or mechanical problems, it may be that the renal function could be affected. And so the report is telling us the injury is not such that it affects renal function. Traumatic renal injury and estimated glomerular filtration rate normal. Carol-Ann, anything you'd like to add, or any comments from?
Just receiving. So Martin has said that they would rather put it in the lab section rather than having it as a split AE.
Yeah.
But it would need to be captured due to the significance of the information.
We talked about that, didn't we, Carol-Ann?
Yeah.
We had the same discussion ourselves, and we actually had a bullet point which pointed that out. You may be capturing it elsewhere, depending on your conventions internally. But we decided that we'd share with you what we would do if we received this as a verbatim term. It may be in a clinical trial, it may not be in pharmacovigilance with a lab field. So it depends. We've just taken it at face value, but we had the same discussion. Okay, I'll hand back to you, Carol-Ann.
Yes, let me share screen.
I was quite quick there. We caught up a bit of time.
So here we are. So our next verbatim is quite short. So no response is reported. Is this verbatim clear and unambiguous? Or is further information needed? Should we raise a query here? You may also have to consider company conventions for similar reports, depending on the data source, whether this is a case from a clinical study or a pharmacovigilance case. So how would you approach such a report? Would you raise a query for the report? No response? What would you do?
Could you check your sharing, Carol-Ann? I don't know if it's me.
Oh, that's strange. Do you see it now? Jane, do you see it?
Yes, Caroline.
Okay. Here we are. No response is reported. The question is whether this needs a query or whether we can code it directly. I see that you're responding already. So most of you would raise a query. So well done. And why would you raise a query on this reported event? No response. Why would you raise a query? What would be the reason for querying it? What would you like to find out? Vague term, yes. It's a vague term. Vague, we would ask for more background, yes. Yeah, we don't know what the no response refers to exactly. So thank you for joining. Let me close the poll and continue with the presentation. So let's search in the browser. So if I search for response, then I have a lot of terms here. Atrial fibrillation, psychic, central nervous, cold shock, cytogenetic, hyperresponsive, hyporesponsive, inappropriate drug response. So it has to do, so obviously it could relate to some abnormality of drug response, loss of therapeutic response, no therapeutic response. So two separate PTs. Loss of therapeutic response has its own PT. No therapeutic response has a separate PT, therapy non-responder, because it means different things. Loss of therapeutic response means there was response before and it was lost, whereas no therapeutic response really refers to a situation where no response at all was there from the beginning. So it could relate to therapeutic response, drug response. But then we have prolonged drug response, therapeutic response, subtherapeutic response. And here we have unresponsive to pain stimuli, unresponsive to stimuli, unresponsive to verbal stimuli. So go to browser. What do we have there? So it's an own PT, unresponsive to stimuli. So we have a reported no response. It's unresponsive either to therapy or to some kind of stimuli. So it's an ambiguous term. And if I look for some non-current term and look for unresponsive, you will see that this again is non-current. So that's why it's non-current. So this red lettering, red square around it, identifies non-current LLTs. And it's grouped under unresponsive to stimuli. So you would always, of course, query ambiguous terms, but if you do not get any answer, then you could really use the LLT that is identical to this PT for coding purposes. This is what Medra does here by assigning the or grouping the non-current LLT unresponsive under PT unresponsive to stimuli. So let me switch back to my slides. Here we are. So similar to what we discussed when looking at the term collapse before, make sure that your verbatim is unambiguous when coding. Always query ambiguous terms unless the verbatim contains additional information that resolves the ambiguity, as we had with our collapse example. And if clarification cannot be obtained, select either LLT unavailable event. You would do so when it is not clear that the report describes a condition in the patient, him or herself, or, for example, a product quality issue. Or select LLT ill-defined disorder if it is clear that the verbatim describes really a condition in the patient. And if some additional information is provided for vaguely reported condition in the patient, there are also other vague terms in MedDRA under the HLT general signs and symptoms not elsewhere classified, like, for example, PT chronic disease, PT condition aggravated, PT disease progression, PT local reaction, PT residual symptom, etc. So ill-defined disorder you would assign when you have no additional information. If you have additional information, you may find a suitable LLT and PT under general signs and symptoms, NEC as well. And this, because this HLT really contains a lot of quite vague terms. And here the related guidance in the points to consider document for conflicting, ambiguous, or vague information. Of course, first we are told to really query such terms. Here, when you don't get further information, you would, here we have an ambiguous abbreviation, GU, pain, could relate to gastric ulcer pain or genital urinary pain. So here you would just capture the underlying medical concept, the pain. If you have vague information, and here you have such examples, turn green, here you would assign unavailable event because turn green could not only relate to the patient, so the tongue turn green or skin turn green whatsoever, but also to a product quality issues, so that a capsule or tablet changed color, for instance. But if you have an information that really the patient was affected by an unclear type of problem, then you could assign ill-defined disorder. So do not make any assumptions here. Always seek clarification from the reporter, but if clarification is not possible, select LLT or under PT unavailable event. So because it remains unclear in our verbatim whether it describes a condition in the patient or whether it refers to problems related to the desired product effect. So that's why we would select LLT unavailable event here. Any questions or comments, Jane?
No questions or comments, Caroline. I think everyone's probably with you on that one. Maybe one that we've puzzled over ourselves at some point. No questions.
Yeah, I saw that quite frequently when working in my company first before. So next
Thumbs
one.
up.
Arthrosis of the jaw is our next verbatim. So can we find a combination term for this reported condition? Can we use synonyms for the medical term arthrosis and jaw for our search? Or do we have to split code here? How would you approach this verbatim? Arthrosis of the jaw. Would you go to arthrosis, localized osteoarthritis, osteoarthrosis, degenerative arthritis, peripheral joint, temporomandibular joint osteoarthritis, or would you go to jaw inflammation? What would you do? I see you're still voting. So we have 50 responses, more than 50 already. So localized osteoarthritis is one of the temporomandibular joint osteoarthritis. These are the preferred options, or just arthrosis, as mentioned in our verbatim arthrosis. So these are the preferred options. Let me close the poll. And let's first clarify the reported condition using a very useful source of information that is available on the internet for free, the MSD manual, the professional version of it. And it's also available in different languages. So we can see that there are some synonyms for arthrosis, like osteoarthrosis, osteoarthritis, degenerative joint disease, hypertrophic osteoarthritis. And we get a description of the signs and symptoms of the disease. So we see that it is characterized by loss of joint cartilage and reactive joint changes. And symptoms include pain that is aggravated or triggered by activity. Patients suffer morning stiffness or stiffness after inactivity, and occasionally they also suffer joint swelling. That's just the summary of the condition. You can see that more detailed information about the classification, pathophysiology, signs and symptoms, diagnosis, treatment are provided in addition. So we see that there's quite a number of synonyms that we could use for our search in the browser. Now let's have a look into the jaw lens. The term jaw could relate to the mandible or the maxilla. The jaw joint is formed by the mandible and the temporal bone, so it's a connection between the mandible and the temporal bone, and it is called mandibular joint, or in medical language, articulatio temporomandibularis. So now let's look into the browser again. And first I would look for arthrosis and search. And of course you have a direct hit here. If I do a right mouse click, go to browser, I would see this LLT in its hierarchy. And you see it's grouped under osteoarthritis, one of the synonyms for arthrosis. And you see others here, degenerative joint disease. You'd see osteoarthritis. What else do we have? Osteoarthritis, arthrosis, osteoarthrosis. So lots of terms in this under this PT. So lots of terms to look for. But if I just look for arthrosis in jaw, in order to find a more specific term, I cannot find anything. So we saw the arthrosis, but there's nothing that would contain the information jaw. Now let's look for jaw inflammation. Here it is. Go to browser. So this is considered, of course, a bone disorder. It's an inflammation of the bone. It's an osteitis. So this would not be suitable, because what we have is an inflammatory condition of a joint, not of the bone. So jaw inflammation would not be correct. So we saw that LLT arthrosis, osteoarthrosis, localized osteoarthritis, degenerative arthritis, peripheral joint are all grouped under PT osteoarthritis, which contains many LLTs that really capture a lot of other joints. So let me again show you. So really a lot of elbow, finger, gonad to the knee, hip, lots of hips, knee, toes. So we have a lot of LLTs, but you would have to look for all different combinations of synonyms and and the localization, the affected site, in order to find a good term. So let's look for, we saw in Dorlins, let's look for the word stems arthro for arthrosis, and mandible. And here we have temporomandibular joint arthralgia, so just joint pain, but we also have the temporomandibular joint osteoarthritis. And we saw that osteoarthritis is a synonym for arthrosis. And if I click on it to reassure myself, I will find it in the hierarchy, and you see that it's just further down. Here it is, temporomandibular joint osteoarthritis. So this is a perfect combination term that we can choose in order to code our reported condition. Oops. Let me switch back to my slides. Here we are. So how did we approach this verbatim? We first used the exact wording of our verbatim, but did not find a suitable match. So for arthrosis and jaw. In such cases, synonyms for the underlying medical concept should be used for the search. Here, synonyms for the reported term arthrosis. And then we would explore the LLTs underneath to potentially also capture the affected joint in this, or the affected body site. In this instance, using synonyms for the term jaw. And with this, our final suggestion is to code to LLT temporomandibular joint osteoarthritis under the PT osteoarthritis. Any questions, Jane?
No comments or questions, Carol-Ann, so far on this one. No.
Okay.
I think everyone's with you. So then I'm looking at the clock actually, we're a couple of minutes short of the past, and I know we haven't got through the two additional ones that we brought along. Sorry about that. We'll carry them over. It's always hard to know how much discussion we're going to have. We have had a few technical problems as well today, so let me share my screen again, and I'll just remind you that we do on this webinar, we do an instant poll. So some of you are already doing that. This is to give you a chance to give us feedback immediately. What did you think of the session? How can Carol-Ann and I improve? We really do take notice of what we get our comments. We try. Can't keep everybody happy because sometimes you ask for opposite things, but we do read it and really try to do what we can. We are going to try to incorporate the suggestions that we've already had for the next session. And if you've got any other suggestions of topics or terms, you can put them in the survey here. So I'll leave you doing that. I'll just move on to remind you that we do record these sessions. We have had some technical problems today. I'm not sure that the recording will be good enough to post. So if it's not able to be posted, we will find some other way to either re-record or do something so we can record something. Just give us some time if there is a problem with it. The other recordings are all available on the web, on the YouTube channel. So if you're new to these sessions, you then have a look back. There is an index, and each recording also shows you which verbatims were covered in that session if you look at the description. So we've been doing it now for a number of years, so there's a whole repository of examples there that you can look through, and there is an interactive index where you can search for terms in a particular therapeutic area or concept that you want to look for. On the contact form, if you want to contact us, do send us an email or any questions you have at any time. We can't code your verbatims for you, but if you have general questions about Medra, you can contact us through the website, and you can join one of our WhatsApp groups there. Scanning the QR code with your mobile phone, you can join a WhatsApp group to share with other people and get news on Medra. Here are some links, and that brings us to the end of our session today. So just remains for me to thank you for your attention. Thank you for your patience with us today. A few little glitches. Thank you, Carol Ann, for your collaboration. Always fun to work with you on these sessions. We do enjoy them. And some nice thumbs up and emojis coming up to show you enjoyed it. Thank you all for your comments. So I'll let you go. Enjoy the rest of your day. Remember, certificates, 48 hours time through the self-service application, and only if you were with us for the whole session or very close to the full session. And then we'll see you in May for our next session. So stay safe, everyone. Enjoy the next few months, and it'll be a bit warmer here in the UK in May, I hope. So,
Or in Germany.
and in Germany. So take care, everyone. Bye for now. Bye-bye, Carol Ann.
Bye,
Bye-bye.
Jane. Thank you. Thank you for joining. Have a nice rest of the day. Bye bye.
Bye-bye.